Cảm ơn các đồng nghiệp. Hôm nay chúng ta sẽ bước vào cái phiên cuối cùng của ngày hôm nay. Và như mọi khi tôi luôn dành những cái bài báo cáo mà tôi cảm giác thú vị nhất dành cho cái phiên cuối này. Không biết người đồng chủ tọa của tôi hôm nay đâu ạ? Trong cái phiên này chúng ta sẽ có 4 báo cáo không ạ? Báo cáo đầu tiên sẽ từ giáo sư Bernard. Chúng ta biết rằng bác sĩ Bernard sáng nay đã có báo cáo. Thì hôm nay sẽ báo cáo thứ hai của Professor Bernard. I would like to invite Professor Bernard to give the first talk today. No, first talk this afternoon, right?
Again, and thank you again to the President of the Ho Chi Minh City Stroke Association, Dr. Tang, for inviting me to give this talk. And this is a revision of one of my talks in the past, and it's inspired by a group unnamed of doctors who truly believe that as long as there's a blocked artery and as long as there's a femoral artery and a radial artery, you should unblock every single artery. And the question is whether the sky is truly the limit. I'd like to start with an illustration of a case. You've all seen this case before, 58-year-old, and I'm well aware that there are those who are still in the prime of their life. So 58 is very young. The new upper limit is 80. And the pre-morbid modifier in score was 0, and he had atrial fibrillation, and he was not on any one of the direct oral anticoagulants. And he presented very early, this is just 1 hour, 15 minutes, with a left hemisphere syndrome, right hemiplegic and dysphasic with an NIHS of 14. And that's the non-contrast CT scan. And for those of you who truly believe in aspects, you can look at this before and after a coffee. Before a coffee, you might say 10. After one coffee, you might say 7. After another coffee, you might say 8. So that's just you. This is a CT angiogram. I put a big arrow there. This is a carotid T-junction terminus occlusion, occluding both the left anterior cerebral artery and the left middle cerebral artery. And I will just put it to you, 1 hour, 15 minutes. With that, who would offer thrombectomy? Maybe put up your hand if you, right? So 1, 2, oh, the rest. I see. So that you're in the minority. So the rest will not offer thrombectomy. Ah, okay. Interesting. Would this change your mind? This is advanced imaging, or modern imaging, CT perfusion, using a software, MyStar, delay time +3 is tissue at risk, just like TMAS +6. That's the green area. And the red area is tissue that's predicted to be dead, so cerebral blood flow under 30%. And there's a bit of a mismatch there. So would that change your mind? Would you still do? Oh, okay, all right. Very aggressive. Okay, yeah, okay. Right. So we did, and this was before the thrombectomy, matching the CT angiogram, occlusion of the internal carotid artery of the terminus. This is what we call a cosmetic result. So angiography looks beautiful. This was what happened. Of course, I'll show you this, right? You know this. Now, so the big questions in medicine requires multiple randomized control study, what we say to change guidelines and to move the needle. So to establish thrombectomy as a way to treat large vessel occlusion, we needed 5 foundational studies. And then to establish that bridging therapy is better, yeah, or at least direct thrombectomy, not non-inferior to direct thrombectomy, we needed 6 studies. And later on, this is a plug, and it's to look at distal arterial occlusion. So those beyond the large vessel occlusion in the distal M2, M3, A1, A2, we needed studies. And there are 4 studies in the world, and ours is Frontier AP, randomized control study. But anyway, so To my knowledge, there are 7 randomized control studies to look at this question of large ischemic core. 3 has been published, so I put a red there. Rescue Japan Limit, published, done. Select2 and Angel's Aspect, this year, published. And because of the positive results of these 3 studies, it became a domino effect. So all the other studies have had to stop, because if they don't stop, they will never get into Lancet or New England Medical Journal. They will probably get into, I shouldn't say this, but they'll get into some of the other journals. Steve, I'll give you my slides, don't worry. So Tesla, by Osama Zaid, that was announced recently at the European Stroke Organization, and Tension and Extreme Last. Extreme Last is from France, from, I think Pierre might know about this, and also Sicario from Australia. They've all had to stop. Now, I've reversed the order a little bit and talk about Select2. And Select2, so both Bruce Campbell and I are on the as the site investigators for this study. And this study randomized patients with a certain core size, and they could come into the study either by CT aspects or by CT perfusion. And this was a bit controversial in that they allowed those patients with an ischemic core of 50 milliliters and above. Now, the cerebral hemisphere is 330 milliliters, right? So 50 milliliters is not even a quarter of half the hemisphere. So you could make an argument, is this truly large ischemic core? Having said that, they included ICA, T-junction, and M1 occlusions under 24 hours, and they looked at shift analysis of the MRS at 3 months' time. And the primary results, well, it was published in New England, and it was a positive study. And they were able to show that those patients randomized to the thrombectomy arm did a lot better than those without. And if you look at the secondary clinical outcomes, so functional independence was 0 to 2, Modified scale. And this is important to remember. Those randomized to medical care was 7% reaching that, and in the thrombectomy was 20%. And that's a recurring theme, because in all the other studies, those patients randomized to medical care was 7%. It was exactly almost the same number. Now, the devil's always in the details, because then you ask, well, if their inclusion criteria was 50 milliliters of ischemic core and above, what's the median of these patients? And then you can look at this. So the median on CT perfusion of the ischemic core, median was 81, or was about 80 milliliters. And then the 25% upper limit was only up to about 119 or thereabouts milliliters. And then when you read the study on its own, you can't get a full feeling of it. You need to go to the supplements. So this is what I call the devil is always in the details. Always read the supplements. This was supplement S16 was well hidden, and this was by subgroup. And for me, this was probably the most important message in this study. And if I could use this and point out to you, so over here, what we have are the different groups in terms of ischemic core size from 70, more than 70, more than 100, and you would well recognize that there's no data of patients more than 150 milliliters. So that's why it stretches to infinity. So we just need to remember that. No data for patients more than 150 milliliters, which is half of your cerebral hemisphere. Remember, 330 milliliters? Right here, just put a mark there. Japan Rescue Limit was a slightly different study. They recruited patients, again, ICA or M1 occlusion, and they allowed for a lower dose of intravenous TPA, 0.6 and 0.9, and they defined large core by either on CT scan aspects and DWI aspects, but not volume automated analysis. This is on aspects. And again, Amarenco scale at 90 days was their primary outcome, but they didn't go for 0 to 2, they went for 0 to 3, and that's reflective when you look at the secondary outcomes. So over here, and again, devil's always in the details, 80% of their patients relied on MRI DWI aspects. So not exactly a CT aspects study when you look at it that way. And I put more notes here. And if you look at the primary outcome, and I put arrows there, now that's 0 to 3. And of course, it's 13%. But if you look at the row below, you look at those randomized to the medical study, the medical arm, again, it was 7% reaching 0 to 2, exactly the same as SELECT-2. Interesting, isn't it? And they were positive. They were able to show that those patients in the endovascular group did better in terms of a higher proportion reaching 0 to 3 and even 0 to 2. And these are my questions for Japan Rescue Limit, because this really essentially is an aspects-based study on MRI scan. And as I alluded to before, the more coffee you drink, the more the aspects will change for you. And it is, and they've looked at that. So DWI aspects, it's not exactly the same as CT aspects. It probably misses by at least 1 point or 2 points. And in terms of volumetric analysis, DWI aspects of 3 to 5 has a very, very wide range. You look at that, 70 to 230 milliliters. That's as wide as my arm. So not exactly very precise. And this was by our friends from China. And for those of you who are interested in just using CT aspects, well, this is the trial. This one, the qualifying event is on aspects. And they allowed both CT aspects or ischemic core volume, but most of the patients were recruited based on non-contrast CT aspects. And this was similar to the SELECT-2 in terms of not using proportional patients reaching MRI 0 to 2, but ordinal shift analysis. And again, randomized to both EVT and medical therapy. And this is just some baseline, but also they did look at it later on in terms of those patients who had CT perfusion scan. And the reason I put this up was, if you can look at this, the median infarct core volume was even lower than SELECT-2. So the median core volume for these patients are only 60, whereas for SELECT-2, it was 80 milliliters was the median. And you can make an argument that perhaps that it wasn't really a large core study, maybe a medium core study. The primary outcome, here we go, on ordinal shift analysis. Patients did better in the endovascular arm. And again, look at the patients randomized to the medical therapy, a little bit higher than SELECT-2 in Japan Rescue Limit, but it was still very low proportion, reaching 0 to 2, 11%. And clearly a lot better in the thrombectomy. So my reading is that there's no question that these 3 studies conducted very, very well. They were all positive, and they all showed that patients who were randomized to a thrombectomy did better, but it was a wider range between 14 to 30% reaching MRS of 0 to 2. But none of these studies really had enough data to support large ischemic core, as in 150 milliliters and above. So for our patients, and I will put my hand on my heart, is that I'm not going to deny any patients having thrombectomy as long as their ischemic core is under 150 milliliters. But when they are more than that, then I think it's an individualized basis. And we await the pooled analysis, individual patient data analysis, not study level, where these 7 studies grouped together and provided with more answers in terms of subgroup, which may benefit or be harmed by thrombectomy, and that's MAGNA. And I will stop there because I need to catch a flight.
Any question for our audience? Thank you, Professor Bernard. I have a question for you. It's, now we have a 3 clinical trial to allow us to do thrombectomy for 24 up to 24 hours with large score. I want to ask you, do we need the perfusion now? Because it's on the trial only use the CT and CTA. So if you perfusion, you can take more time. Thank you.
I think we can look at that two ways. One is that how much do you trust yourself in reading a non-contrast CT scan when it comes to its aspects, because that keeps changing the more coffee or the more beer you drink. So I think there's a question of precision. And also, if you are speaking to your colleagues, their aspects range may not overlap with yours. So I think there's the inter-rater and intra-rater agreement problem with just using aspects. And the second thing is that we're now no longer dealing with just patients who are eligible to go into trials. Those patients who have an MRS premorbid of 0 or under 80 years old, we now have to deal with much older patients with complex anatomy, tendon occlusion, with a premorbid MRS of 2 or 3. The more information that we have, the better it is for us to discuss risk and benefits to the patients.
Thank you. Any question from audience? Okay, please.
Xin chào. Cho em hỏi là trong trường hợp can thiệp, tụi em không có MRI perfusion, chỉ chụp được cái MRI diffusion thôi. Trong trường hợp mà lâm sàng cái điểm cái MRI diffusion thấy cái tổn thương khá rộng, tuy nhiên cái điểm nick thấp. Cũng có một vài trường hợp là bệnh nhân vào viện với cái trường hợp nick tầm khoảng dao động từ 8 đến 10 điểm thôi, nhưng mà cái tổn thương trên MRI là khá lớn. Thì theo ông thì cái việc can thiệp đó có được khuyến cáo hay không?
Sorry, I'm just waiting for Google Translate to translate what you said to me, but it's too slow. Can someone help me?
Em nói tiếng Việt hả?
Em nói gì? Tại nãy anh không, xin lỗi anh.
Dạ, tại em xin hỏi là một số trường hợp mà bệnh nhân vô viện cái điểm nick thì thấp, nhưng mà cái tổn thương mình thấy trên diffusion là khá lớn, thì cái chuyện mà khuyến có nên là can thiệp hay không ạ?
Thực ra câu này chắc chắn là không rồi, tại vì trong các nghiên cứu lõi lớn người ta đâu có lấy nick thấp, đúng không?
Không thấp, nhưng mà không thấp nhiều thầy. Thấy cái tổn thương tắc chẳng hạn như tắc ICI hoặc MCI, nhưng mà có tổn thương lớn, nhưng cái điểm nick của người bệnh dao động từ 8 đến 10 điểm.
He want to ask you about indication for thrombectomy for the case with a low nick score, but large infarction from the DFUI.
Yeah, my favorite topic. So large vessel occlusion, for example, like an M1 or an ICAD occlusion, or even an M2 occlusion with a low NIS, for example, a 2 or even a 1, what do you do with it? This, I find, advanced imaging, especially CT perfusion, helps you really a lot, because when you do CT perfusion, you would know about the volume of tissue at risk. Let's say, for example, either delayed time +3 or Tmax. In this kind of patient, low NIS, and let's say a 100 milliliters, or a 150 milliliters tissue at risk. These are the patients you know, if you don't open up the blocked artery, they're going to move on to infarct that entire area. So I always believe that anterograde flow is better than retrograde flow, right? Yeah, so you really need CT perfusion for these patients.
Okay, thank you. Thank you very much. We move to the next speaker. The next speaker will be Professor Andrew Wong. He will come to talk about ICAD, the new frontier of hyperacute stroke management, to stent or not to stent, and what to do after stenting. Hẹp động mạch nội sọ, một cái bệnh lý mà rất hot ở Việt Nam. Trong giai đoạn tối cấp của đột quỵ, chúng ta có nên đặt stent hay không? Và những cái điều chúng ta cần làm gì trong tương lai?
Xin chào. Come on. Thank you for the invitation to speak. I will talk today about intracranial atherosclerotic disease. These are my disclosures. I don't perform endovascular thrombectomy, but I'm happy to talk about this topic. And as you know, intracranial atherosclerotic disease is much more common in Asian populations than in the Caucasian population. And you can see that the rates in the Asian population much higher than in the bottom in the Caucasian population. So you see much more intracranial atherosclerotic disease here than in some other countries, where a lot of our trials were done. So I can understand it's a difficult topic when we haven't got as many large clinical trials to guide us. So I will talk about how we can tell before the procedure that the large vessel occlusion is due to ICAD, what we can do before the procedure if we think there is ICAD involved, what we can do during the procedure, although I understand most people here are not interventional doctors, and what we should do afterwards. So one of the ways that we can tell if the patient has ICAD along with their LVO is to look at the scan, the current scan from today and previous scans, and if we see watershed infarction, that might suggest that the patient has chronic hypoperfusion and has had previous symptomatic or asymptomatic stroke from the ICAD and the stenosis. We can listen to the history, and if there is a history of hypoperfusion TIAs, for example, when the patient is dehydrated, when they are unwell with infection, when someone has increased their antihypertensive medication, if those situations bring on TIAs which are very stereotyped, very similar every time, that might suggest that the patient has had ICAD with hypoperfusions to TIAs before today's stroke. We can obviously look at previous angiography. If someone had normal artery where the LVO is in the past, especially recently, it is unlikely that they have developed ICAD in a short amount of time. Sometimes I think we forget that this may not be the first scan that our patients have had, and if we ask more questions, we might find that they've had previous CT scan of the brain with angiography sometimes before today's stroke. We can also look at the location of the occlusion. ICAD often occurs at the bifurcation where the arteries bifurcate, but the LVO from ICAD is often truncal. In other words, the clot travels towards the bifurcation and it tends to occlude at the bifurcation if it's cardioembolic or atherosembolic from the neck or the heart. But if the LVO is related to ICAD within the main vessel, the clot will stop. And it should not stop in the middle of a vessel if the vessel is normal. So LVO occurring within the trunk of the artery does suggest that perhaps the artery was not normal before the embolus and might imply that there is ICAD. We can also look at the plain CT for calcification, which might imply atherosclerosis is present because a heavily calcified artery is more likely to have atherosclerosis in it. This is one of my patients who has a right ICA stenosis that you can see on the angiogram on the left of the screen. But on the plain CT, that section of artery in the cavernous sinus had over 250 Hounsfield units of CT density, which really does suggest that that artery wall did not have normal radio density and implies that that artery wall had ICAD in it. We can also look at the shape of the occlusion. So if this is what the artery looks like with the yellow plaque in it and the red thrombus in it, we don't get to see that during the CT angiogram. What we see is the contrast, and the contrast fills the vessel, and then the arrows, they continue but down and to the right, but to the left, you can see the contrast stops because of the occlusion, and a tapered shape to that occlusion might suggest that we're dealing with ICAD and not an embolism with a flat edge. Patients with ICAD might also have hypoperfusion in the longer term and develop better collaterals. And so this sometimes means that even though the patient has an LVO, they have a low NIH that Professor Yan was discussing, a low NIH but a very big penumbra. And as we said, those are the patients who we think we should treat because they may proceed to infarct the entire territory of that artery. So if we see a small core and a large penumbra, especially further down after the stroke has occurred, which means it's not because the patient is a slow progressor, then perhaps we're dealing with ICAD. So what can we do if we think that there might be LVO with ICAD? Well, it's very reasonable to use aspirin and clopidogrel before the procedure because we are anticipating that we may need to use a stent. And if we are going to use a stent, then we want the antiplatelet effect of these medications to start as soon as possible, not after the stent has been placed. So we can use the antiplatelets early so that the platelets are fully inhibited prior to the stent being placed. It is difficult to know what to do if the patient has already been thrombolyzed, and it is worth discussing what to do at the very first point when you decide on your reperfusion strategy, because at our centre, if the patient is in our emergency department and they can go up to the angio suite and have the thrombectomy, we might think about withholding the thrombolysis in favour of dual antiplatelets and primary endovascular thrombectomy, even though we know that there's equipoise in the literature about withholding thrombolysis prior to EVT. If we think there's ICAD present, we might withhold the thrombolysis and proceed straight to endovascular thrombectomy. During the procedure, the interventionalist may find that a very small clot burden is present. And this is because for cardioembolism or carotid atheroembolism, the vessel is occluded completely with clot. In a patient with ICAD, some of the vessel occlusion is actually due to the ICAD, and only a smaller amount of the lumen occlusion is due to clot. So a small clot burden might suggest that the patient has ICAD. But obviously the interventionalist will also do an angiogram after removing the thrombus, and they may also see that the vessel is stenosed. Another feature of ICAD is that the vessels tend to re-occlude quite quickly after the procedure has been completed. We also might find that if we start with contact aspiration, in other words, sucking out the clot, it is less effective in patients with ICAD. And that's because the catheter can't actually make contact with the thrombus if it's hidden further down and blocked by the atherosclerotic plaque. Also, when the stent is deployed across the occlusion, the stent will expand to take up the shape of the stenosed vessel, and it may be more obvious to us at that point that the vessel is not a normal calibre and the vessel has a stenosis in it. So these are the ways that we might think that we are dealing with ICAD before the procedure or during the procedure. And then we think about the stent, because that's one of the most important things that's different between endovascular thrombectomy with ICAD and without. There's not very much evidence that we should place the stent as primary treatment. And there's nothing important about this slide except to say that we don't have much evidence about placing the stent directly. However, it may be very useful to consider using a stent if we try to do endovascular thrombectomy and cannot. The ESO has a guideline, but very unclear when looking at the evidence whether or not angioplasty and or stenting should ever be done. And this seems to be a very rich field for research. As I said before, it may be difficult to maintain vessel patency after endovascular thrombectomy in people with ICAD. And so the Taiwan Stroke Society guidelines suggest that we wait and see if we think there is ICAD present, that whether or not the vessel re-occludes after the thrombus has been removed, And if the vessel re-occludes, then we should place a stent in that situation. So perhaps a second angiogram 10 or 20 minutes later might be helpful within the procedure. There's no evidence, but some proceduralists will place a stent every time they remove a thrombus from someone who has ICAD. And there's no evidence to say that that is the right or the wrong thing to do, but people will see that done. What else can we do to keep the vessel open? We can prescribe glycoprotein 2B3A inhibitors during the procedure. And we know that we can use torofiban or eptifibatide. There is some evidence that those patients who have those products administered during their procedure have a better clinical outcome with better MRS scores at 3 months. In our centre, we do not use abciximab. It is not a reversible agent, and I think we would move towards using one of the other two. But all of that happens in the procedure. In my centre, I don't get contacted very often during the procedure. Most of the time, the interventional neuroradiologist makes all of those decisions without me. But they do call me afterwards to talk about antiplatelet usage after they've done the procedure. And so what do I tell them about keeping the artery open today? I said before that we could use antiplatelet medication if there's no thrombolysis. Sometimes we've already given the thrombolysis. We didn't know there was ICAD. We had to place a stent to maintain vessel opening, and we give the antiplatelets anyway to keep the vessel open, even though the patient's already had thrombolysis. I don't know how often that's done in other centres, but we often find ourselves in that position, possibly because in Australia we don't always think about ICAD because it's not as common before we do the procedures. We can think about using aspirin or clopidogrel monotherapy as well after the procedure. It's a well-established standard of care, but often the patients are already pre-exposed anyway, and so we can tell ourselves that we are going to withhold antiplatelets after the procedure. But if the patient's already been taking those medications up until today, their platelets are already inhibited. And then we can also use dual antiplatelets to keep the arteries open for 21 to 90 days, depending on your local interpretation of the chance and particularly the point study. A couple of words about aspirin and ticagrelor. In our centre, we don't use much ticagrelor. We would use the platelet function studies, and if we find clopidogrel resistance, we would use ticagrelor instead of clopidogrel. I know other centres have assays for CYP2C19 and use ticagrelor if there is a loss of function carrier, as with the CHANCE-2 study. So one of those options might be good to choose whether to use ticagrelor. In our centre, most of the patients get clopidogrel first, though. We will do a CT angiogram the next day to make sure that the artery is still patent and that the stent has not occluded. If the stent has occluded, it's not clear what we should do because the point of the dual antiplatelets is to keep the stent open, and if the stent's already closed, the dual antiplatelets is not going to reopen the artery. But we think about what to do in that situation. Sometimes the patient has atherosclerosis in the carotid artery as well, and we want to continue the dual antiplatelets to prevent a second stroke from the carotid artery atherosclerosis. So we worry on the one hand that if the vessel has occluded, then what is the point of using the antiplatelets for that vessel? And then we also think, well, if the vessel's re-occluded, then what is the harm? The dual antiplatelet therapy can't get to the infarct core, so it's not clear what should happen at that point. We have to manage blood pressure. There is some evidence about what to do, and I won't spend too much time on this, but the Enchanted-2 MT study, almost half of the patients had ICAD, and in that study, in that trial, we saw that the patients who had a target systolic blood pressure of under 120 did worse than the patients with a target of 140 to 180. And one of the concerns that we have is if we're pushing very hard for a very low blood pressure, no matter what number you choose, if the artery reoccludes, what happens to that arterial territory? The lower that we aim for the systolic blood pressure, the worse it is for that patient if the artery reoccludes, because the more likely that territory will infarct quite quickly, often overnight when no one's watching that carefully. We don't have any specific management advice for blood pressure management longer term. We have some guidelines which I won't talk about too much. I just leave them there and say at the end that we don't use ticagrelor in Australia mostly because it costs more than clopidogrel does. I think that if they cost the same to us, we might use more ticagrelor, but at the moment it's much more expensive than clopidogrel is. On the other hand, for many years in my country, clopidogrel cost more than aspirin, and it was much more difficult to access because of that. And even when clopidogrel became off patent and much more cheap and less expensive to prescribe in my country, we did not see a big shift towards clopidogrel. So I'm not sure that that would happen with ticagrelor once ticagrelor is off patent. Lipid management, we've heard an excellent talk earlier this afternoon about lipid management. We don't have any specific randomised controlled data on how to manage lipids after placing a stent for ICAD. We still use the same target LDL of 1.8 millimoles per litre. There was some interesting data about perhaps if we push the LDL very low, that some of the intracranial atherosclerotic disease might actually regress, which is probably less important for patients who've had a stent placed, but many patients have multiple vessels with atherosclerosis, and especially for those patients who've got perhaps hypoperfusion TIAs. There's not many options that we have without going into neurosurgical procedures, not many options that we have to maintain perfusion through a stenosed ICAD-affected vessel. Might have ICAD because we can look at the location and the shape of the occlusion and other findings on our imaging. We can do things differently in the lead up to our procedure if we suspect that there might be ICAD. We can treat acutely differently during the procedure, and we do have management advice for the longer term, although it's generally the same, although there will be slight differences in the antiplatelet usage after stenting because of the need to keep the stent patent. I'll stop there and take questions. Thank you very much.
Thank you very much for your talk, Andrew. I have a question for you. You say in your center, if the patient you think is acute stroke with a large vessel occlusion, and you think the mechanism should be maybe ICAD, you can cancel thrombolysis and go directly to thrombectomy because you're afraid maybe we do stent later, right?
So yes, it's a difficult decision matrix, because my feeling is that the longer the time it is between when the thrombolysis is given and the EVT occurs, the more benefit there is. So for the patients who present to my hospital directly, I'm not sure that they derive much benefit from the thrombolysis if they can go straight up for EVT. I think for the patients who have to fly to my hospital from 6 hours away, those patients I'd probably give the thrombolysis to, regardless.
Yeah, because I asked you because it's the first thing we very, very hard to tell is the ICAD or
yes.
Cardioembolic stroke. And the second one, if you're looking for the direct safe, in the rufusation, it's much better if the pitching compared with direct thrombectomy. So I'm afraid if you cancel for thrombolysis for those of cases, is not the good choice.
Yeah, most of the time we will give the thrombolysis because we are quite commonly, as you suggested, in a position where we've already given them thrombolysis. We have to give the antiplatelets because of the stent. and we become more comfortable with the patients having everything and they don't bleed. So we might think about withholding the thrombolysis, but we usually give it.
Các đồng nghiệp có câu hỏi gì cho ông Professor Andrew Wong? Một cái bài rất là hay. Các đồng nghiệp nào có câu hỏi xin bước ra cái microphone.
Dạ, em xin được đặt một câu hỏi là em có một bệnh nhân sau khi một bệnh nhân vào viện với đột quỵ liệt người phải và đã giờ thứ 3, và sau khi dùng tiêu sợi huyết xong thì chụp mạch máu là có hẹp FCA bên trái đoạn M1 90%. Vậy thì với tình huống này thì mình sẽ làm gì tiếp theo ạ? Dạ em chết ạ.
Xin lỗi, bệnh nhân có phục hồi không ạ?
Dạ không ạ.
Hẹp 90%, tức là vẫn còn dòng.
Dạ
đúng không ạ? Tôi thấy lạ, bởi vì nếu hẹp 90% thì thường bệnh nhân nó sẽ chắc chắn sẽ cải thiện. He wants to ask you.
EVT in the patient who has a 90% stenosis of the left MCA.
She got the acute stroke patient. Come to him is a 3-hour window, and he gave the TPA, and then the patient go to CT angiography and found it's a severe, very severe stenosis. It's 90% stenosis. He asked you, should we put stent for this patient?
Yeah, I think that's a very difficult decision. We don't have much evidence for what to do in that situation. But I could see, though, that the situation is very similar to a situation when the thrombolysis was ineffective and the artery had to be opened using EVT, and then we found the 90% stenosis. So whether we get to finding about the 90% stenosis is because of thrombolysis or spontaneous lysis or EVT, we still have a 90% stenosis that we need to secure, and many times we will stent that patient because it doesn't matter how we got to that situation, we still want to keep the artery open. But I'm interested if other people do things differently, but that's how we would probably manage that.
Yeah, please.
Thank you. I have a question about maybe the case we had talked a little bit before. That's the case that we have a large occlusion of a vessel, a large vessel, for example, M1, and we had just very mild stroke. At that time, for example, and NIS about 5. So what should we do at that time? Can we you do the thrombectomy or not? Large occlusion and very mild stroke.
So LVO.
Yeah.
But small NIH.
Yeah.
Yeah. I would probably copy my colleague, Professor Yan, and look at the CT perfusion, because the tissue at risk, the penumbra with the delayed perfusion, is going to give me an idea of the likely natural history if that LVO is untreated. It sometimes depends for us what time of the week it is as well. Because if the patient comes in on a Friday and we have a low NIH and a moderate penumbra with their LVO, we might remove the clot just so that we can secure the artery before the weekend, because in my hospital we don't have very good staffing on the weekend to watch the patient. During the Monday or Tuesday, we can just admit that patient and watch them very carefully. I still worry, though, that overnight and as time goes by, they get a little bit worse every day and we never take the clot out. They end up just infarcting all of the tissue over 3 or 4 days anyway. So I think it's very reasonable to take the clot out.
But the problem is for some patients we have seen that after doing the thrombectomy, maybe there is a bigger post-operative,
yes.
bigger stroke.
Yes, so this is the problem that we face, that the patient with the low NIH stroke score, it's very hard to make them better, isn't it? And very there is risk in making them worse with the thrombectomy procedure, and sometimes we worry that the risk of the procedure will outweigh the benefit of the thrombectomy. But I think the situation is a little bit similar to a stenosed carotid artery with a minor stroke or a TIA, because we know the natural history is, well, we don't know the natural history for EVT, but we know the natural history for endarterectomy is that although the operation on the neck for the endarterectomy may cause morbidity and sometimes mortality, the natural history is bad enough in selected patients that we should do the endarterectomy. For LVO with low NIH, I think it's becoming more clear that the natural history is bad in most patients, but we very much await the outcome of the randomized controlled trials to prove that. So I'm not sure that I'm right.
Yesterday, Professor Henry Ma teach us about perfusion. He said with the patient with mild NIH score and LVO, we're looking for perfusion in MRI or CT scan. If the Tmax is over 6 seconds over 65 mil, we should go, right, Professor Henry Ma? Yeah, because it's the Tmax is over 65, even this score is low. The predict the outcome is very poor. Okay. Thank you, Andrew. We move to the next speaker. Sorry, we have one more question.
Dr. Wong, I have a question. Can you share your experience about angioplasty or DCB for ICAD in acute stroke? Thank you.
What were the two options? Could you repeat the two options for ICAD?
You can share experience about angioplasty by balloon or DCB.
I don't think I have a strong opinion because I'm not an interventionalist. I'm not sure what the right approach is and which patients should have which procedure, I must say. Yeah.
Okay, thank you. Cái bài ngày hôm nay của Professor Wong là đặt stent rescue, tức là đặt stent khi mà chúng ta thất bại với tái thông, nó khác với đặt stent trong phòng ngừa thứ phát các anh chị. Ngày mai chúng ta sẽ nghe một chuyên gia cũng đầu ngành của châu Á về chuyên về hẹp động mạch sọ, đó là giáo sư Thomas Long. Được xem là một người rất nhiều kinh nghiệm về stent động mạch nội sọ. Giáo sư Thomas Long sẽ nói về cái chỉ định chúng ta phòng ngừa thứ phát trên các bệnh nhân chỉ định stent hoặc trên các bệnh nhân hẹp động mạch nội sọ. Hy vọng rằng cái bài ngày mai lúc 8 giờ sáng sẽ rất là thú vị, bởi vì Professor Thomas Long là một người rất có nhiều kinh nghiệm trong cái bệnh lý hẹp động mạch nội sọ. Chúng ta phải chuyển sang cái báo cáo viên tiếp theo. Xin mời.
We would like invite Professor Stephen Davis in your presentation, current state and future direction of mobile stroke unit. Thank you.
Well, thank you very much. And I'm giving this talk on behalf of myself and my close friend and colleague, Jeffrey Donnan, because we've been in it together from the beginning with our mobile stroke unit program. But I want to start off by really thanking our Vietnamese hosts from the Ho Chi Minh City Stroke Association and the Stroke Academy of Australasia, and acknowledge Professor Tang and his team, Professor Henry Ma, Professor Andrew Wong. This has been a marvellous meeting. Now, we talk constantly to each other and to our patients about the principle that time is brain and every minute counts. But I think the main focus of the time is brain mantra has really been on ischemic stroke for both TPA and indeed for endovascular thrombectomy. But it's a principle that also holds true for intracerebral hemorrhage. Here's a graph of hemorrhage expansion after onset of intracerebral hemorrhage. You can see that intracerebral hemorrhage is a dynamic process one of the main experimental avenues to treatment is to try and stop the bleeding, and the intervention has to be very early. Similarly, perhaps less known is that although surgery for intracerebral hemorrhage remains not completely proven, the evidence overall is that surgery reduces mortality and that earlier surgery is better than later surgery. So this really underlines the concept of what mobile stroke units are all about. The basic concept is that you bring the hospital to the patient, you treat the patient in the field, outside the home, and it's very well established now that this saves time and improves clinical outcomes. So I'll just define what a current mobile stroke unit is. It's a specialised ambulance. This is the one in Melbourne, but it looks very similar to most units around the world. It includes a mobile CT scanner, shown here. This is the Ceratom scanner made by Samsung. It enables you to do both CT and CT angiography, and it includes a point-of-care laboratory and a mobile stroke team. These are our data from Melbourne, basically showing timescales 0 to 1 hour, which we call the golden hour, where you increase the rate of thrombolysis with TPA or tenecteplase by about tenfold, going from 1.5% to 18%. And then probably even more dramatically, if you look at what we call the silver hour, the first 90 minutes after stroke onset, you increase the amount of thrombolysis given compared with standard emergency departments from around about 12% to around about 50%. So treatment is delivered fast, and faster treatment gives better outcomes. So this is our own experience in Melbourne. We have increased the golden and silver hours very, very dramatically compared to emergency departments. We've shortened the time to thrombolysis by about an hour, and we shortened the time to thrombectomy, which I'll show you. And this is really the global experience. This is the stroke team. We currently have a doctor on the mobile stroke unit, an expert nurse here, a radiographer, and 2 paramedics. So it's a large team of 5 people. The doctor on the truck will almost certainly be replaced by telemedicine, and we're currently undertaking a trial to show that the neurologist working remotely in the hospital and communicating to this group, particularly to the nurse practitioner, can reduce the numbers on the truck from 5 to 4, but it's still a large unit. This is a meta-analysis showing from the published studies the degree of time savings by giving thrombolysis in the field. This is our own, shown in red, the time saving in Melbourne, and it's variable around the world, but you save somewhere between 20 minutes and an hour in most of the studies that have been performed by performing thrombolysis outside the... I'd like to conclude by saying the theme of mobile stroke unit care is taking the hospital to the patient, improving outcomes, and although the benefits are established for the metro MSU, rural and remote patients require innovative solutions with very lightweight scanners linked by digital technology and telemedicine. And this is game-changing and relevant for many countries. And I know that Jeff and I would like to acknowledge our research team, large group of people involved in this program, our national champions and influential champions in Australia, and our special partners. But I'd particularly like to thank you, come on, in Vietnam. Thank you very much indeed.
Thank you very much, Professor Steve and Davis. Just a small question for you. How much for the new scan?
How much?
How much, yeah.
Money?
Money? Yeah.
Yeah. So when we developed this grant, we thought these devices had to be lightweight, portable, and affordable, cheap. So we don't know yet. This will be a decision of the companies. But the current CT scanners in mobile stroke units, as you know, are close to, in Australian dollars, $1 million, $750,000 in Australian, perhaps $500,000 US. We think that these will be, certainly the EM Vision, well under $100,000, maybe cheaper, and the Micro X, maybe 100, maybe 200. We don't know yet, but it will be much, much cheaper than current CT technology. And we see that they will be used not just in mobile platforms, but also in small clinics and small hospitals where they don't currently have CT capability.
Thank you, sir. We move to the last speaker. Question?
Just a small question. Okay, thank you very much. Mobile stroke units is our dream. But I think that for the conditions of Vietnam where the circulation is not good, I mean the road is not good in cities and in countryside. But what do you think about the setting the system mobile stroke units in Vietnam is okay? Because I think that I would like to ask Dr. Thang also, because in Vietnam we haven't got enough. For example, I know there are some private hospitals we haven't got enough money to buy it, but I don't know why until now we haven't got any center having a stroke mobile in Vietnam. I don't know. I would like to ask your advice and about the advice from Dr. Thang. Thank you.
Thank you. I didn't understand the full question, but I know one of the main barriers in Asian populations is going to be traffic movement, going to make portable units very, very difficult. Again, other innovative solutions are required. And it may be, I mean, who knows, in 5 or 10 years' time, it may be technology that can be delivered by drones. Doctors could communicate with a device dropped and then people come to the scene. So I think it's an evolving field and there's going to be different solutions for different social environments.
Okay, thank you. We move to the last speaker today. We come back with Professor Amarenco. He will talk about update of on antiplatelet therapy for stroke prevention.
So hello again. So you have heard most of the of what I would say, but I will try to give a slightly different perspective. So we all know that the risk after a stroke or a TIA is front-loaded, and most of the risk occur within the first hours and the first days. So it is an emergency, exactly as an acute stroke. That aspirin is effective in reducing the long-term risk of stroke, and the risk reduction was 19%, and for ischemic stroke it was 22%. And this report by Charles Swallow back in 1998, 25 years ago, it was an analysis of IST and CAST trials showing that surprisingly aspirin was very effective during the first hours after the prescription, after onset, with a 20% reduction within the first 3 hours. So a very effective, surprising effect of aspirin compared to non-aspirin in these trials. And it was further evaluated by Peter Roswell in his landmark meta-analysis in the Lancet 2016, looking at early aspirin use in the same trials. And you can see that most of the effect of aspirin occurred during the first days after the prescription of aspirin. So a very effective compound, which is aspirin, which is clearly the gold standard of the acute stroke treatment when you cannot use revascularization therapy. And this analysis also showed that the effect of aspirin was maximal within the first 6 weeks, even within the first 12 weeks, and thereafter the effect looks very mild. And in fact, in these trials, in the meta-analysis, the result of aspirin versus control was driven by the early effect of aspirin during the first 90 days. So the guidelines, as you know, recommend aspirin prescribed within 24-48 hours in patients who cannot receive revascularization therapy. On the long term, we have the CAPRI trial with a modest effect of clopidogrel over aspirin, which was mostly driven by patients with peripheral artery disease in this trial. And then the MATCH trial compared clopidogrel to clopidogrel aspirin and found that there was no beneficial effect of the combination over clopidogrel with an increased risk of intracerebral hemorrhage. So the DAPT therapy for the long term has been killed by this trial. In fact, in this trial, like in many others, there was a lacunarization with 50%, more than 50% of the patients with small vessel disease. And probably this subgroup drove the risk of bleeding. In the Prof trial, the combination aspirin dipyridamole compared to clopidogrel showed a neutral effect and with an increased risk of bleeding, again, with dual therapy. In both trials, there was a lacunarization. In MATCH, 55%, in PROFESS, 52%. We know from the SPS3 trial that SVD patients with small vessel disease have a high risk of increased intracranial hemorrhage. And we know that patients with small vessel disease not only have lipohyalinosis, but also have micro deposit of hemosiderin outside the small artery, probably due to a porosity of the wall of the small artery. And this may be the reason for an increased risk of bleeding. We don't know, in fact. On the long term, the COMPASS trial evaluated the combination of rivaroxaban and aspirin versus aspirin. And as you know, the primary outcome was significant with a CV death and stroke reduced by 24%. The group of patients with stroke, there was, the outcome stroke was also reduced by 42% in the aspirin rivaroxaban group. So this may be a way in the future to treat patients long-term, to combine aspirin with an anticoagulant. And you know that currently there is the Oceanic stroke trial ongoing using not 10A inhibitor, but 11A inhibitor combined with aspirin. And you see that the risk of bleeding was not really increased, although the hazard ratio is 1.5, it was not significant. Coming back to clopidogrel plus aspirin, it was shown potentially effective in this meta-analysis within 90 days. And that was a background to do the CHANCE and POINT trial. And the CHANCE trial as you heard today, showed a 32% relative risk reduction in stroke, and the POINT trial found also a 25% relative risk reduction compared with clopidogrel aspirin compared to aspirin, at the expense of an increased risk of bleeding, which was moderate, but 2 times higher than in the control group. Most of the benefit occurred within 21 days in POINT, as you can see on this slide, with a 35% relative risk reduction within the first 21 days and no reduction thereafter, meaning that the resulting POINT was also driven by the first 21 days of the therapy. Putting chance and POINT within 21 days showed that there was a beneficial effect during the first 3 weeks with a 34% relative risk reduction, with a slight increase in hemorrhage, 2 times higher, in fact, which was not reaching significance, but probably a matter of power. However, clopidogrel has shortcomings. Clopidogrel is a prodrug, as you know, that require bioactivation by cytochrome P450. CYP2C19 loss of function carriers have less efficacy than non-carriers, and you know that this is true in up to 40% of patients in China. And you see here the chance sub-analysis with CYP2C19 loss of function allele carriers versus non-carriers, and you can see that non-carriers were driven the result of the chance trial. Here, carriers versus non-carriers with aspirin, non-carriers with clopidogrel aspirin. So ticagrelor is another P2Y12 inhibitor, but with a direct action. It is not a prodrug. It does not to be metabolized by the liver. Ticagrelor binds reversibly to the receptor on the platelet, which is not the case for clopidogrel. And so an antagonist can be developed, and you know that one antagonist is in evaluation right now in phase 3. And also ticagrelor has a faster onset and a higher platelet inhibition than clopidogrel, and a faster offset compared to clopidogrel. So on the paper, ticagrelor is much better than clopidogrel. And also you can see here that the platelet inhibition is immediate the first day with ticagrelor, and is sustained over the 14 days after. Although with clopidogrel, the variability of the response is very wide the first day, of course, but also during the 14 days thereafter. This is why we did the Socrates trial comparing comparing ticagrelor to aspirin monotherapy, and there was a lot of discussion whether we should use all ischemic stroke, or if we have to split and focus on atherosclerotic disease. In fact, the company chose to have all ischemic stroke, but we did a sub-analysis on atherosclerotic stenosis. So in Socrates, we randomized patients to ticagrelor versus aspirin. At 90 days, overall, there was not a beneficial effect. At least the p-value was 0.067, so not lucky. Interestingly, the effect of ticagrelor over aspirin during the first 30 days was significant, with a nominal p-value of 0.01, justifying the follow-up trial, which was the Thales trial. But first, look at the results of the Socrates trial. Overall, we saw that there was no significant result, but had we choose stroke as an outcome, ischemic stroke, it would have been positive, or even stroke, it would have been positive. So we were not lucky with this trial. But there is a potential for ticagrelor, because you see that compared to aspirin, there was no increase in hemorrhagic stroke on ticagrelor, on the blue line here, and no increase in major bleeding also. And we did a sub-analysis, which was pre-specified from the very beginning, to look at ipsilateral atherosclerotic disease group. So among the 13,000 patients, there was 3,000 patients with ipsilateral stenosis. And you see that compared to aspirin, patients on ticagrelor had a much less recurrent stroke, MI, and death, with a 32% relative risk reduction, which was very significant. So very interesting results with ticagrelor in patients with ipsilateral stenosis, particularly because in the 10,000 other patients, there was almost no effect. You see the hazard ratio was 0.97, with a significant interaction with p-value of 0.017. So this interaction is very important because it indicates that ticagrelor may be a potent agent to test in future trial to confirm what we saw in this sub-analysis of the Socrates trial, to confirm that ticagrelor may be a very important addition to our armamentarium in patients with ipsilateral atherosclerotic stenosis. So we did the Thales trial comparing ticagrelor plus aspirin versus aspirin, with a 30-day endpoint, and as you know, there was a 17% relative risk reduction. Unfortunately, the company again chose to not focus on atherosclerotic stenosis, and we found that there was an increased risk of bleeding, 4 times the risk of bleeding, which was totally driven by small vessel disease patients. Before coming to atherosclerotic subgroup, I would like to mention that there was an interesting results in Thales showing that subsequent ischemic stroke had a reduced handicap on ticagrelor versus placebo, with the ordinal shift, which was significant, with a p-value of 0.002, as you can see here. So there was an impact of ticagrelor on disability. Ipsilateral atherosclerotic group has been also evaluated, and you see that there was 21% of the sample. You know, there was about 9,700 patients in Thales, and so 2,300 had an ipsilateral atherosclerotic stenosis, and there was a 27% relative risk reduction, again in this subgroup, with an NNT of 34. And this is the numbers here on aspirin and ticagrelor aspirin, NNT of 34, 27% relative risk reduction. And you can see that in the other group, about 7,000 patients, there was almost no effect. So clearly, the patient with ipsilateral atherosclerotic stenosis are the target for ticagrelor plus aspirin. Interestingly, also in this subgroup of ipsilateral atherosclerotic stenosis, there was very few major bleeding and a number needed to arm of 951. This is why I said that in Thales, the risk of bleeding was driven by patients with small vessel disease. To follow up on the CHANCE trial, the CHANCE group did a comparison between clopidogrel aspirin and ticagrelor aspirin in patients who were poor clopidogrel metabolizers. And you see that there was a 23% relative risk reduction with ticagrelor aspirin compared to clopidogrel aspirin. Unfortunately, the good metabolizers were not included in this trial, so this is something that we are missing. So how to choose between clopidogrel aspirin and ticagrelor plus aspirin after CHANCE-2 trial? The 2021 AHA recommendation said that clopidogrel plus aspirin should be used for during the first 21 days. And this is a level 2A recommendation. And ticagrelor plus aspirin can be used. And this is a level 2B recommendation, both followed by antiplatelet monotherapy. However, we know that 25 to 40% of patients are poor clopidogrel metabolizers, meaning that patients put on clopidogrel plus aspirin may only be on aspirin monotherapy. So if the patients cannot be tested quickly for CYP2C19 loss of function allele, and to do this test, we need to do it within 3 hours maximum, so it's a challenge. Then the option is simply to give ticagrelor plus aspirin to all patients, particularly with ipsilateral atherosclerotic stenosis, to be sure that patients are being on actual dual therapy. Of course, it would be better to have a trial showing in patients non-carriers for CYP2C19 that this is also true, that ticagrelor plus aspirin is better than clopidogrel plus aspirin. Now there has been the report of INSPIRE-DAPT trial, again done in China. It was a factorial plan, in fact, with DAPT, and the other arms were with statin, atorvastatin 80 milligram. But this is the INSPIRE-DAPT part trial, comparing clopidogrel plus aspirin to aspirin 24 to 78 hours after onset. And as you can see, there was a 22% relative risk reduction on clopidogrel plus aspirin compared to aspirin, but there was an increased risk of bleeding, twice more bleeding on clopidogrel plus aspirin. So before using clopidogrel plus aspirin beyond 24 hours and until 72 hours, we should weigh the benefit risk of the patients. So what about the long term? We know that from the TA registry that the long-term risk is high and continuously increases over time, over the 5 years. So on the long term, we are left with aspirin and clopidogrel right now. But what is the place of ticagrelor? We have seen in Socrates atherosclerotic stenosis patient that ticagrelor monotherapy reduce the risk by 33% at 90 days compared to aspirin. So it will be very interesting to look at the effect of ticagrelor on the long term. So we have started the risk TETIS trial in France and soon I hope in Canada. 2,800 patients with ischemic stroke and ipsilateral stenosis, randomized to colchicine versus standard of care, no colchicine, in the reducing ischemic inflammation in ischemic stroke with colchicine. And the patients are re-randomized in a factorial plan to ticagrelor versus aspirin. So we will have, on the long term, since the patient will be followed 3 to 5 years, we will have on the long term the effect of ticagrelor versus aspirin. In conclusion, aspirin reduces the 6-week risk of ischemic stroke by 60% and the 6-week risk of disabling stroke by 70%. Aspirin is the only antiplatelet treatment that demonstrates efficacy in reducing disabling stroke or death within the first 6 weeks. In pooled analysis of chance and point, clopidogrel plus aspirin was 34% superior to aspirin in reducing stroke within the first 31 days. The INSPIRE-DAPT trial extended the benefit of clopidogrel plus aspirin to 72 hours after onset, but we should be careful in weighing the benefit-risk ratio because there is an increased risk of bleeding, potentially. Compared to clopidogrel, ticagrelor is not a prodrug with no variable effect, and it is 100% effective. It has a quicker onset of effect, a higher platelet inhibition, quicker offset of effect, and has an antidote in phase 2, now phase 3, in fact. In Socrates trial, ticagrelor was not superior to aspirin in reducing stroke, MI, and vascular death, except perhaps stroke alone, and on patients with ipsilateral atherosclerotic stenosis. In Thales trial, ticagrelor plus aspirin was superior to aspirin alone in reducing stroke or death and recurrent disabling stroke. And Chance 2 found ticagrelor plus aspirin superior to clopidogrel plus aspirin in poor clopidogrel metabolizers. And that should be recognized in clinical practice because patients with ipsilateral stenosis, if you put them on clopidogrel plus aspirin and they are poor clopidogrel metabolizers, then they will be only on aspirin. And the TETIS trial, which is ongoing, is evaluating ticagrelor monotherapy versus aspirin monotherapy on the long term. Thank you for attention.
Thank you very much, Professor Amarenco, for a lot of information from subgroup of ticagrelor in some Socrates and Thales. Because, you know, in Vietnam, we recruit a lot of patients for Socrates and Thales. And I remember it's 1,000 for each Socrates and Thales Vietnamese patient recruited in Thales and Socrates. So, any question from audience?
Yeah,
please.
Thank you, Professor Amarenco. Yeah, the question is about using antiplatelet in the case of AF-associated stroke patients, atrial fibrillation associated with cerebral infarction. That's because, according to the current guidelines, we have to wait for about 1 or even 2 weeks to begin anticoagulant for the patient. Even with the latest ELAN trial, we have to wait until 1 week with the moderate or large cerebral infarction. So in that period of time, in that gap of time, for example, 1 or 2 weeks for waiting for an anticoagulant, should we use antiplatelet, for example, aspirin, clopidogrel, or even ticagrelor, or should not we use any platelet at all in that case of the,
So the question is about giving antiplatelet treatment before starting on oral anticoagulant.
Yeah, but particularly with the moderate or large cerebral infarction.
So usually these patients are put on aspirin monotherapy. If they have a large infarct, I don't think that we can use the dual antiplatelet therapy because, as you know, it was an exclusion criteria in clinical trials. So I would use aspirin before starting oral anticoagulant.
Yeah, only
That's it.
aspirin.
Pardon?
Yeah. Only aspirin.
Only aspirin,
Yeah. Thank you, Professor.
Based on the subgroup, we found that the ticagrelor is maybe better, maybe much better with intracranial stenosis patient.
Could you speak?
Sorry? Based on Socrates and Thales, we found that the ICAD subgroup is more benefit from ticagrelor, right? Because ICAD is very important cause in stroke in Asian. In Vietnam, we have a lot of intracranial stenosis.
Yeah, in ipsilateral atherosclerotic stenosis patient, there was intracranial and extracranial atherosclerosis. So ICAD was, of course, included in this analysis.
And if the patient have ICAD, and how long you recommend for to combine aspirin and ticagrelor?
Not more than aspirin and ticagrelor, 30 days.
How long?
30 days.
30 days, okay, 30 days. And then we can switch to ticagrelor or aspirin. Look like aspirin clopidogrel, huh?
I know that the guidelines say that in ICAD we can use for the long term clopidogrel plus aspirin. It was based on the Sampris trial. It was not randomized, so we don't know, in fact. And so I'm not sure that we should use on the long term clopidogrel plus aspirin in ICAD patients. I would prefer to randomize aspirin versus ticagrelor.
But in Thales, we combine aspirin and ticagrelor in 30 days and increase the risk of bleeding. So maybe we can use 2 weeks. Yes. 2 weeks is maybe safety.
It increases the risk of bleeding in all patients. If you focus on patients with ipsilateral atherosclerotic stenosis, there was no increase in bleeding.
So thank you. I have a patient, 75 years old, prehistory of diabetes, hypertension, but he has ICAD bilateral, and also stroke, ischemic stroke in the right side, occlusions in the MCA. But the question is, in this case, what we can give for the patients in the preventive management, because I try to do blood list for treatment, but after transfer to monotherapy, she has some TIA. But I would like to add your advice. Thank you.
In patients with MCA stenosis, you mean? Yes. So if I understand well, you put the patients on dual therapy, and then there was recurrence when you stop the dual therapy. Okay. We need to have more trials for the long term. And currently, we don't have a trial that showed that dual therapy is better than monotherapy, including in intracranial stenosis. I think that we should test this properly in a clinical trial. We should also test monotherapy aspirin versus more potent drug like ticagrelor. This is what we do in TETIS trial, in which we include ICAD and ICAD. There are also other potential way to address the risk of recurrence, which is, for example, anti-inflammatory drugs like colchicine and in the future treatment that target proteins of inflammation. We have we have also the possibility to increase the lowering of LDL cholesterol So we have a multiple way to address this recurrence, not only by giving dual therapy. We don't know whether it increases the risk of bleeding because we don't have, again, a clinical trial. So we need to be careful and to do clinical trials.
Okay, thank you very much. Chúng ta sẽ kết thúc cái phiên cuối cùng ngày hôm nay. Rất cảm ơn các đồng nghiệp đã có mặt ngày hôm nay. Ngày mai chúng ta sẽ cũng còn rất nhiều các cái bài thú vị, đặc biệt là cái update của những cái nghiên cứu mới từ xuất huyết não Interact 3. Thì hy vọng sẽ được gặp lại các đồng nghiệp vào sáng sớm ngày mai.